Good evening. It's a pleasure to welcome you to today's ESDS webinar on thoracic trauma management. And it's my pleasure to introduce two speakers who will do an Oxford-style debate on the topic. I'm glad that we have Didier Lardinois, who is the head of the Department of Thoracic Surgery in Basel, with us. And his position will be that early rib fixation is the key to good outcome after rib fracture. And for the opposing view, we have Erik de LoosHeerlen who is a thoracic and trauma surgeon from Zuiderland Medical Center in the Netherlands. And his position will be that a conservative approach can yield better functional outcomes after rib fractures. So we will have both of the speakers presenting their point of view and then a rebuttal session. And thereafter, there will be a discussion with you in the audience. And as always, you're welcome to place your questions in the chat or in the Q&A function, and we will discuss them afterwards. So Didier, you start with your presentation, and we're looking forward to it.
Yes, wait a minute, I go to the Zoom again. Hier vrijgeven is here and here. Is it okay like this?
Yes, you just have to start the presentation mode. Yeah, perfect.
Okay. Good evening, everybody. It's a pleasure for me to participate to this webinar. And I will try to convince you that the early rib fixation has many advantages for the patient with rib fracture. I don't think that it's the key to good outcome. I see the key is the selection of the patient, like in surgery. The indication for operation is also very important and maybe the key of success. I have no conflict of interest. I will begin my presentation with a bad case, what I consider like a bad case. You see the story from a 62 years old patient. He was working in a terraced garden and fall 2-3 meters. You see he was referred in a reference center. In this reference center, there were a thoracic surgeon, there were a traumatologist. You see on the chest CT scan that the patient presented with hemothorax with several rib fractures, especially on the left side with fragment fractures. The patient was initially hemodynamically stable and he received a chest tube, like you can see. 3 days later, the patient suffered from dyspnea, and a new chest CT showed a shift of the mediastinum to the right hemithorax, again an hemothorax, and a huge herniation of the stomach on the left side. The patient underwent an operation. The thoracic surgeon performed a thoracotomy, evacuate the hemothorax, make the reposition of the stomach, and closed the injury of the diaphragm, but nothing to the chest wall. You see here the chest X-ray when the patient left this reference center, and you see a progressive shrinkage of the left hemithorax. The patient were transferred to another center, reference center, also their thoracic surgeon, traumatologist, and he was transferred there for osteosynthesis of the clavicular. But nobody checked anything to the thorax. There were absolutely no control. And then the patient consulted me 3 months later with pain, with an important disability, with dyspnea, with a loss of performance. And then we decided to operate on this patient, but of course it was not a minimal operation, minimal invasive operation anymore. It was an open operation with refixation of two ribs with bone interposition. I have seen now the patient 4 months after the operation. He does well. But what I want to illustrate with this case is, of course, the bed interdisciplinarity, the bed selection. For me, from the beginning, there were an indication to fix the ribs with these fragment fractures. It was not done. After again a bad interdisciplinarity, a bad communication, after the patient was transferred in the second reference center. And you see the consequence. Fortunately, the patient is doing well now, but we cannot speak about minimal invasive surgery in such situation. I will divide, or I have divided my talk in two parts. We will first speak about the situation with fly chest, and after the situation, most common series of fracture. For the fly chest, you have here a summary of what is possible to find as good paper in the literature. And I think for the fly chest patient, the question is not anymore to think if it's necessary to fix the flight chest, but it's more the timing of the fixation of the flight chest. I will show you two retrospective studies showing with a relatively acceptable number of patients, showing that in flight chest patient, the chest wall fixation has also an advantage in terms of mortality in comparison to the conservative treatment. The timing of the operation in this study was not an independent risk factor for mortality, but anyway, the authors could see that early fixation within 3 days was associated with a significant reduction of prolonged ventilation. And you know that prolonged ventilation is, of course, associated with several potential complications. The second study is also a retrospective one, but also with an important number of patients. And here again, the operation was associated with a clear advantage in terms of mortality in comparison to the conservative therapy. A multivariate logistic regression identified the operation as the only risk factor associated with decreased mortality. The cutoff was 4 days. It means that for patients who underwent the operation after 4 days, there was no difference in the mortality anymore. If we have a look now, concentrate on the studies dealing with the timing in patients with flight chest, you have here a summary of the most important and recent studies. The results have to be considered with caution because these studies are retrospective and in many cases including only a relatively small number of patients. Anyway, you have the study by Otaka from the Japanese nationwide database with more patients, and they showed that in this situation, the early surgical stabilization of a rib fracture was associated with a shorter overall duration of hospitalization, duration the stay on the intensive care unit, the mechanical ventilation, and reduced cost, and also less complication like pneumonia. I show you another study, a recent study is published in 2023. It's an interesting study because it's a randomized one, and they compared fixation in flight chest and patient with more than three dislocated ribs. The flight chest was in about 55% of the patient included in these studies. And they also shown that an early fixation in this patient has several important advantages. An interesting study was the study by Pieracci in 2018, and you see, yes, it was a prospective one, including 550 patients, and he looked at the follow-up and the outcome between patient operated within the first day after trauma versus medium. It was 1 and 2 days, and late after 3 days. And he could say that, see that each additional day to the operation resulted in an important increase, likelihood of pneumonia or prolonged mechanical ventilation or rate of tracheostomy. It means for Pieracci, the conclusion was that the delaying a surgical intervention has a negative impact on the patient outcome. It's clear to understand why in patient with flail chest an early fixation has several advantage, because if you operate, if you fix the flail chest, of course you restore the chest wall biomechanics. It means that the patient is able to return to an independent ventilation and to prevent all the potential complication due to the prolonged intubation. Also, during the operation, many of these patients with flail chest undergo a thoracoscopy, and during the thoracoscopy, there will be an evacuation of the hemothorax with rinsage, also preventing complication like empyema, for example. It means that I think there are enough data in the literature to say that, and it's also recognized in several guidelines from the Eastern Association for Surgery of Trauma in the publication of Kazotakis, and also the guidelines of the Chest Wall Injury Society, to say that in patient with flight chest, it's better to fix the flight chest if possible, of course, and as early as possible. The thing is that, again, we have to correct, to make a proper selection of the patient, and I will show you, it was an algorithm I have published already 7 years ago nearly, and I will try to go in the different category of patient. Of course, if you have a patient with flail chest and you have to operate urgently on this patient, then you should fix the flail chest. I think it's clear. The other situation is the situation I have mentioned before. In this situation, it's a big advantage to fix the flight chest within 3 days. These patients have very often an extended anterolateral or lateral flight chest. And I show you an example without, of course, severe associated injuries. It means that it's possible to operate the patient relatively early, like this young woman who was attacked by a bull, and you see nearly each ribs on the left side was broken. Of course, in this situation, if it's possible, if the patient has no severe associated injuries, to fix this flight chest as soon as possible. Another situation to fix a flight chest as soon as possible is a well-known example situation of patient after cardiac reanimation. As soon as the patient has been given free for operation, you can fix then the flight chest. In this situation, the sternum itself is the unstable part of the chest wall. You can fix it like we have done here with bilateral, anterolateral, small thoracotomies, or with a nurse bar. They also center performing the operation like this. Another situation, this has changed now in comparison to what I have published 7 years ago. It was the patient with extended lung contusion or severe cerebral damage. Then it was advised not to operate such patient with flail chest because uh, people thought that the patient could not benefit from the operation. Anyway, they have to remain intubated, and the indication for fixation was only in the case of difficulty to wean this patient. It was then indication, delayed indication to fix the flail chest, normally after 2 or 3 weeks. Now this there it's not like this anymore. There are several publications showing that in mild contusion, and I mentioned the study by Van Weyck, or in moderate contusion, then it's possible and advisable to operate to fix the flight chest as soon as possible to reduce the need for high PEEP in patients with already compromised lung. But anyway, in the study of Van Weyck, they shown that in patients with severe contusion, I insist, it's important, more than 2/3 of the volume of the hemithorax, there was no difference in the results. The same result was seen by Kocher. It was a study from Switzerland. He has shown that the operation can be beneficial in patients with flail chest and contusion, but the severity of the contusion was the main independent predictor for prolonged mechanical ventilation. In patients with severe traumatic brain injury, it was well known that it was a contraindication, as I have mentioned, to fix the flight chest because the trauma itself was considered the main prognostic indicator, and the induction of anesthesia and operative manipulation might negatively affect the intracranial pressure of this patient. Again, it has changed a little bit, and there are several studies. I have mentioned two, the study by Prince, the study by Lagasse, showing that in selected case of patient with cerebral injury, it is an advantage to fix the flight chest in this patient. They have less complication, and also an advantage to do it as early as possible within the first 3 days after the trauma. I think for patients with lung contusion and traumatic brain injury, again, it's very important. The interdisciplinarity is very important, and to select the patient, I think in selected case, it's possible then to fix the flight chest as soon as possible to avoid complication of prolonged ventilation. The last indication to fix a flight chest, it's what I have called the early stabilization, are such situation patient who are on the normal ward with a peridural catheter or any other sort of pain therapy. At the beginning, the thorax you see on the chest X-ray looks quite good. And after, during the first day, generally it's during the first day, it's possible to see a progressive shrinkage of the thorax. And that's why in this situation, it's absolutely necessary to fix the chest wall as soon as possible. Normally, such situations are seen in about 4 to 7 days after admission in the hospital. Also, if the patient has not much pain, I insist to say that it's absolutely necessary to fix the flight chest because they will have pain one day, and then it will be too late. You will have several non-union fractures and fixed pain, and then if you operate the patient later as a salvage procedure, it's too late, and generally the patient cannot recover. Now, the second part of the presentation, the series of fracture. Here, I have to say that there are not many data in the literature comparing the conservative therapy and the operation, and also nearly nothing about the functional outcome, long-term outcome in this patient. It means this type of fracture of subgroup of patient are a topic of debate in the hospital, and it's a common situation in our daily business. Anyway, and it's for me important this, the goal of an operation in this subgroup of patients is not to restore the biomechanics of the chest wall, like in patients with flail chest. It's more and nearly only to improve the pain and to enable the patient to make an earlier return to normal activities. It's an important point for me because you will see in our concept, it will be a therapy case by case according to the subgroup of patient. It means also that the pain therapy is really play a central role in the therapy of this patient, according to the possibility to place a peridural catheter or not, because there are several contraindications, according to the local experience also and the patient's needs. Normally, classically, the patient, if possible, receive a peridural catheter, and before it was usual to observe the evolution of the pain of the clinical signs about 1 week, and after, if it was not possible to see any improvement, then to think about an eventual operation in this patient. Uh, what about the literature in the patient with painful series of rib fracture? As I said, nothing very strong. You see here some series, small series of patient own experience showing that rib fixation in this subgroup of patients seems to improve the pain control and the functional results. In our study published in 22, we could see that the improvement of the quality of life could long till 1 year. But again, it was not a comparative study with the conservative group. An interesting study by Pieracci, again, including 110 patients, shown that at 2 weeks, it means when the operation in such patient with series of fracture was performed within 3 days, at 2 weeks already, the pain score was significantly lower, the quality of life better, the narcotic consumption lower, and less complication in comparison to the conservative group, showing showing an advantage of the operation and of an early operation in this subgroup of patients. Now, and before to conclude and to show you how we proceed in our division, an important question is it uh, indicated to fix series of rib fracture in old patients because they are frail, and of course an operation in such patient can be also associated with more complication. I have chosen two studies, relatively recent studies in 23, published in 2023, showing that in the elderly, they have considered patient older than 60 as old patient, but they have compared with younger. They have compared the conservative therapy with the operative treatment, and they have seen in both studies that the mortality was better in the operative group in comparison to the conservative group. And it was also interesting in the study by Zhang to show that at 9 months, the group of patients who underwent the operation had a higher fracture healing rate. It means less non-union than the conservative group, because in the elderly, it takes longer, the fracture healing takes a longer time. There is I have only found one relevant studies. It was a retrospective study by very old patients, older than 80, And they have again compared operation versus conservative therapy. And you see that it was an advantage to operate on this patient early. That's why I've chosen this study, because it was a question of timing, less mortality in the operated group. They had in this study more pneumonia in the operated group, to be honest, uh, showing again that the patient are frail. And that's why, again, the selection of the patient is the key of success. Now, do we need really prospective randomized trial in the patient with series of fracture to compare the conservative therapy with the operative therapy? It's always the argument for the colleague, physician, who don't think that the operation bring anything. They say, come on, why do you want to operate on the patient? There are absolutely no prospective studies showing that the operation bring anything. I think we should uh, consider the operation and the conservative therapy not like two, how to say, treatment against each other, concurrential treatment, but as alternative treatment. And I think it's uh, justifiable to inform the patient that it's possible to be operated already for such group, several groups of patients, subgroups of patients. I show you after, already after 2-3 days. We don't wait 1 week anymore like before, according to the age, the physical characteristic of the patient, the physical activities in all their life before trauma, profession, etc. And because we know that the operation in many, many cases is effective, easy, can be performed in the acute phase minimal invasively with an acceptable morbidity. And that's why we propose again for the therapy of series of fracture, if you have to operate the patient urgently for something else, hemothorax, in the majority of the case, we perform a thoracoscopy. We can find, for example, a lesion of the diaphragm. We can suture it with VETs. Then, of course, we fix the ribs if they are dislocated. Again, in selected patient, we offer already the operation after 2-3 days. These patients are patients with severe dislocation to avoid the complication of non-union. Old patient, but selected old patient. I mean, old patient who have still a good quality of life and are able to live independently at home, or sporty patient. They want to have a tournament of golf, I don't know, or bicycle. Of course, we don't wait. Why should we take the risk for this patient to wait and that they have chronic pain? I give you some example for the very early, what we call very early fixation. Here you see dislocation of rib fracture with the impaction. Here dislocated, we operate this patient. We don't wait. We propose, we offer minimum. The patient can decide, of course. I agree or not, but we offer already the operation after a couple of days. Another example here, an old patient with anticoagulation and with hemothorax and dislocated rib fracture and pain. The patient is in bed. You ask your resident, how is the patient? He says, very good, everything okay. You go in the room, the patient is not able to cough. He says, everything is okay if I don't move. It's not the goal, of course, because you know that these old patients can have very easily a pneumonia, and the pneumonia with this age has a very high mortality. You are not able to put any peridural catheter. The patient was anticoagulated. You are not able to give non-steroidal anti-inflammatory because of the kidney function in many cases. If you give morphium derivatives, then you can have problem, delirium, etc. That's why as soon as the effect of the anticoagulation um, is over, we propose systematically the operation in selected patient of this subgroup. And the last example is here a patient, 67 patient. At the beginning on the chest CT, you see the fracture, but they are not dislocated. And after a couple of days, you see a progressive dislocation. It's clear indication for us to fix the ribs. You see here a view by thoracoscopy with the deformity of the chest wall before and after the operation. And you see that it's very interesting when we perform the VETs during the operation, we find not seldom more than what expected on the chest CT scan. It's not seldom to see interposition of lung and of tissue in the fracture, what is of course a risk factor for the development of non-union. Now, if I try to summarize, in the first category of patient with flight chest and timing, there are clear indications for chest wall stabilization in patient with flight chest. It's included in guidelines. Of course, the interdisciplinarity is required for selection, especially because these patients are polytrauma patients and have in many times additional injuries. And it's recommended, if possible, then to offer the rib fixation as early as possible, within 3 days. In patients with series of fracture, the pain management is a cornerstone of this treatment. A good pain management may prevent rib fracture surgery. It's possible in the future with introduction of the cryoanalgesia, for example, that we will operate less on such patients. On the other side, the rib fracture surgery, it's our experience, is a very good pain management in selected patients, and the decision to operate is the key of success, and the timing also should be considered case by case based on the daily clinical evaluation of the patient and on physical activity level of the patient before trauma. It means it needs selection and clinical experience. And again, and this is important, we see each week's patient and the consultation coming with a late complication, patient of rib fracture, treated conservatively with fixed pain, with loss on function and non-union. And I think it's important to realize that a rib fracture should be considered seriously, and that it's naive to think that each rib fracture can heal spontaneously. Thank you very much for your attention.
Thank you, Didier, for this comprehensive presentation of your viewpoint. So let's switch to Erik's presentation.
Yes. So.
Perfect. Thank you.
Let me try to share my screen then. Can you see my presentation, Clemens?
Yes, yeah, works perfectly fine.
Well, thank you very much for the kind invitation. Didier, thank you very much for your excellent talk. And well, as you invited me to be the opponent of Didier, my talk will be on the conservative approach for rib fracture patients. These are my disclosures. And I have a small disclaimer to announce because I'm a both thoracic and trauma surgeon with a special interest in chest wall surgery for congenital cases like pectus, but for trauma cases as well. So I'm a real rib fixation enthusiast, but well, it's always good to keep in mind that not every rib fracture patient benefits from a surgical approach. That's what we're going to discuss the next couple of minutes. So what are our learning objectives? I will start with a short introduction, then we will discuss chest injuries, surgical rib fixation like Didier already did, the downsides of surgical rib fixation, and I will end with some take-home messages. So thanks again for the kind invitation. And when you asked me to take place in an Oxford-style debate, I had to check what an Oxford-style debate was. And it's an old form of a debate, which currently is better known as a pro and con debate. So during my preparation, I started with, well, Googling my opponent, which is a good friend of mine and very highly esteemed thoracic surgeon from Basel. And Professor Lardinois has a big emphasis on chest wall reconstructions. He organizes several courses on this subject, an annual course in Basel, a very nice workshop, which I attended several times already. So they teach you in 1 or 2 days every aspect of chest wall trauma, rib fixation with different anatomical models, different implants. But I have to say that maybe my opponent is a little bit biased by that. So that's always good to keep in mind when you make up your mind on these talks. So rib fractures is a common injury. There's a large variation in severity, and well, these are a lot of a little bit older data, but all the data show that 90% of rib fracture patients have associated injuries as well. They're known for their high mortality rates. 50% ends up in an ICU, and 30% is referred to rehabilitation center afterwards. There's a correlation between the number of rib fractures and mortality as well, and that mortality is associated with the associated injuries, but for example with AIDS as well, and a comorbidity like COPD. This is a retrospective cohort study from the National Trauma Data Bank from the USA, more than 60,000 rib fracture patients, and those data show that there's a big increase in morbidity and mortality with the number of fractured ribs, and if there are 6 or more fractured ribs, the mortality even doubles. So it's an important issue, and there's a decrease in quality of life being reported as well. So rib fractures are a big problem for our patients. These are some data from the most recent survey in the Dutch Trauma Registry, 2023. In the Netherlands, there are more than 70 million inhabitants, and in 2023, there are more than 70,000 registered trauma patients, and of those patients, 12% suffered from some form of thoracic injury. If you take a close look at those data, and if you consider the more severe chest injuries, the AIS of 3 or more, 13% of those injuries are in or around the chest region. And of those more severe chest injuries, more than half of those patients suffer from multiple rib fractures without a field segment. What about the diagnosis? Well, we start with physical examination. We always survey our patients according to the ATLS principles. And during physical examination, there could be a high index of suspicion for chest wall injury as well, due to pain, tenderness, or crepitus, for example. During the primary survey of ATLS, we standardly perform a chest X-ray as an adjunct, and it's a perfect modality to rule out or diagnose a major hemo or pneumothorax. But it's difficult to see the amount of rib fractures, so it leads to an underestimation of the severity of the chest wall injury. So nowadays, almost every unit has a low threshold to perform a 3D CT scan with 3D reconstructions to get a proper idea of the amount of fractured ribs and the morphology of those. Well, the treatment of rib fractures historically is conservative, so non-operatively. And like Didier already mentioned, adequate pain relief is the cornerstone of that treatment. And you could use either oral, IV, or epidural analgesia. Pulmonary hygiene is important as well. So the patients were classically put on TriFlow, physiotherapists went by, and sometimes, if necessary, the pulmonologist performs a bronchoscopy. And if necessary, sometimes patients end up on mechanical ventilation. And because not all of those treatments had excellent results, there was still a lot of morbidity and mortality. A century ago, some of our former colleagues tried to, well, fixate some ribs, apply some operative treatment with, well, the images that you can see in this slide. Big incisions, a lot of tissue damage, a lot of improvised fixation techniques. And you can imagine that those operations didn't have that success rate that we expected from them. But luckily, new implants were developed 2 decades ago, beginning of this century. And nowadays, we have an armamentarium of dedicated implants for rib fracture surgery, titanium, pre-contoured plates with angular stable locking options, special clips to perform your surgery and fixate the ribs. So that led to an increase in popularity of surgical rib fixation. But the question is, how important is that increase, and is it more a hype or is it a real need or real demand for rib fixation? And I think, well, maybe 10, 15 years ago, we were on the peak of inflated expectations. This is a curve showing that, well, maybe we performed too many surgeries on too many patients. In other words, there's a fracture, I need to fix it, and we didn't make the proper indication for those patients. So what are our indications for surgical rib fixation? Well, flail chest is the most important one, but multiple single rib fractures as well. We can treat costal margin injuries, non-unions of prior rib fractures. We can address iatrogenic fractures after thoracotomy, and we can use plates and screws for chest wall reconstruction, for example, after a resection for oncological purposes. So to start with flail chest, it's stated that the surgical rib fixation for flail chest reduces pain, reduces pneumonia risk, reduces the indication and the duration of mechanical ventilation. It reduces the length of ICU and hospital stay, and some studies or some colleagues advocate that the mortality rate is being reduced as well. And for me, these patients are no-brainers. That are patients with gross amount of chest wall instability, they're on ventilator, they can't be weaned, they can't breathe spontaneously. And if you open it up, you can see the gross amount of instability. With some simple plates and screws, it's very easy to restore anatomy and thereby physiology. This is another example. Very unstable chest wall, hemothorax was already drained. Direct lateral approach was being performed with preservation of the latissimus dorsi muscle. And you can see the huge amount of instability, which was perfectly addressed with the application of few plates and screws, leading to this end result. So for me, these cases are no-brainers. They benefit from surgical rib fixation. And if you take a closer look at literature, a lot of colleagues agree. This is a consensus statement already 15 years ago, being published by Fred Pieracci from Denver. And in that consensus statement, our colleagues state that surgical rib fixation should be considered in all patients with flail chest injuries and should be considered in multiple severely bicortical displaced single fractures. And if we decide to perform the surgery, it should take place as soon as possible, but preferably within 72 hours. But if you take a close look at literature, there's only scarce literature. There are only a few studies being published, predominantly retrospective in character. Data are very heterogeneous. There's no overlap in published data. There's, for example, no clear distinction between patients with a clinical flail chest versus a patient with a radiological flail segment. It's not clear which patient was ventilator dependent, and the definition of outcome parameters is very poor. This is a Cochrane review of all already 10 years old, included 3 randomized controlled trials, randomizing surgical rib fixation versus non-operative treatment, 61 versus 62 patients. And this Cochrane review shows a significant reduction in pneumonia and tracheostomy rates, shows a lower frequency of chest wall deformities, but there was no difference in mortality. Studies were underpowered, but they were not able to pull data to draw conclusions on the duration of mechanical ventilation, length of hospital stay, and length of ICU stay. This is an overview of more recent data of all the systematic reviews and meta-analysis being published over the last couple of years. And most of those studies show small benefits for surgical rib fixation in terms of pneumonia rates, mechanical ventilation duration, and length of hospital stay and length of ICU stay. But when you take a look at the multiple single rib fractures, the level of evidence is even lower. There's a lack of consensus, lack of evidence, and in general, there are good results after non-operative treatment. And there's some downsides of surgical rib fixation as well. So in other words, it's always good to keep in mind the number of rib fracture patients you want to treat versus the number you need to harm with your procedure. This is an overview of all comparative data on non-flail chest patients, and you see that there is hardly any evidence supporting standard use of surgical rib fixation in those patient categories. Already mentioned by DJ, the CWIS non-flail study published in 2020 by Fred Pieracci and Thomas White, for example. And it consists of a multi-center RCT. 12 centers joined this study. and patients were randomized between surgical refixation within 72 hours versus medical treatment. The primary outcome measure was pain scores after 2 weeks, and to be honest, there were several methodological shortcomings. When you take a look at their results, they included 110 patients, and there was a significant lower NRS after 2 weeks following surgical refixation. But after 2 weeks, there was no difference. And there was no difference as well in terms of secondary outcomes. For example, the use of narcotics, the risk of pneumonia, length of stay, spiral place complications, and quality of life. This is another study from Australia, randomized controlled trial, 2022, surgical refixation versus non-operative treatment in non-ventilator dependent chest wall injury patients, and inclusion criteria were 3 or more rib fractures. Their primary outcome was pain rating index after 3 months and quality of life. They included 124 patients in 4 years' time, and their conclusion was there was no improvement in pain or quality of life after 3 and 6 months. This is the most recent randomized controlled trial from the Netherlands, the FIXCON trial, which randomized in multiple centers from the Netherlands, patients with either multiple rib fractures with NRS scores of 6 and higher, despite adequate pain relief, or patients with severely displaced rib fractures. And the preliminary short-term results were recently being published. 180 patients were included, 90 in the refixation arm, 90 in the non-operative treatment arm. There were no baseline difference in baseline characteristics, a little bit higher ASA scores in the refixation group, and a little bit more sternal injuries in the non-operative group. And the conclusion of this large study is that there were no difference in pneumonia rates and no difference in 30-day complication rates compared to non-operative treatment. So if there's no strong evidence, it's always good to take a look at the downsides of surgical refixation. And to be honest, surgical refixation, especially for the multiple non-flail patients, is a very invasive form of analgesia. It causes surgical trauma, it uses resources, there are high costs involved, and there's a risk of complication. And you could ask yourself the question, is this push for surgical refixation maybe industry-driven? So what are those complications we're talking about? For example, neurovascular injury, wound infection, fracture-related infection, pneumothorax or an empyema. Some patients suffer from hardware failure, and chronic pain is a very important issue. So this is another study from Switzerland and the Netherlands, retrospective cohort study, surgical refixation, more than 3 rib fractures. Inclusion period was 2010 to 2018. And the patients were sent follow-up questionnaires, asking them for their quality of life, level of dyspnea, return to work, implant-related irritation, and the implant removal rate after 12 months. And to be honest, 31% of those patients reported implant-related irritation. This is a systematic review published a few years ago, focusing on the complication rate and outcomes after surgical refixation in both flail and non-flail chest patients. 48 studies with almost 2,000 patients being included, and in this study as well, a high complication rate, implant-related complication rate of 10% is being reported. Well, let's take a look at one of my own cases then. This is a 70-year-old male, suffered from a blunt chest injury, isolated chest wall injury with a flail segment. He wasn't doing well, had high pain scores, he wasn't breathing sufficiently, so we decided to perform surgical refixation, VETS assisted. So we rinsed his pneumothorax, we fixated his ribs, and he recovered very well. Chest tube was removed, he was discharged within a few days, so everyone was happy. Until he came back after 1 month with this CT scan, pleural effusion, empyema, and a large abscess at the location of the osteosynthesis material. So we took him back to theater, we rinsed his pleural cavity, we debrided his chest wall, and it took him months to recover with oral antibiotics, IV antibiotics, and we discussed the option of hardware removal with him after consolidation of his fractures, but he refused the secondary surgery. And finally, after 4 years of problems, he consented for hardware removal. We operated him, and afterwards he recovered well. So the infection rate is rather low, but if patients suffer from an infection, it could be a major problem in terms of costs, resources, and most important for the patient itself. So especially in multiple single rib fractures, non-flail chest patient selection is crucial. And you have to take a close look to the patient itself, to the chest wall injury pattern, the associated injuries, and the expected technical difficulties of your procedure. So in other words, you have to outweigh the benefits versus the harm you cause. So what are technical difficulties in surgical rib fixation? For example, the bilateral injuries. It's crucial that you decide on your positioning of your patient. For example, in this case, prone position. Sometimes there are bilateral incisions being necessary to plate your fractures. So there's a lot of soft tissue dissection needed. There's some areas which are hard to reach. For example, in the axillary region, or sternal region, the costal margin, the retropectoral region, or the retroscapular region. Some patients suffer from severe comminution and poor bone quality. There weren't large incisions, large plates to stabilize the highly comminuted fractures. So that could be a challenge as well. And some patients suffer from soft tissue loss, for example, stripping of the intercostal muscles, and you have to be creative to sort that problems out as well. Luckily, there's some new trends, some improvements in the area of surgical rib fixations. Nowadays, we try to be as less invasive as possible. So we, instead of the large muscle cutting incisions, nowadays we use smaller incisions, more targeted, muscle sparing, thereby causing less tissue damage and improving patient recovery. So this is an example of a minimal invasive approach. We use VATS, like DJ said, to rinse out the chest cavity, to address the additional injuries, for example, the diaphragmatic tears, to rinse out the chest cavity, to apply proper pain relief, and then via small muscle sparing incisions, we can address most parts of the chest wall just via small incisions of just a few centimeters. Techniques have been improved as well, luckily. For example, the implants. So nowadays, there are new implants on the market, for example, the Niti-Rib system, which are nitinol clips, which have a shape of memory alloy, and they become shapeable below 5 degrees Celsius. So if you put them in ice, you can bend them. And if you apply them to your rib fracture and heat them up with some warm saline, they return to their original shape. And the use of those implants allow you to work as minimally invasive and muscle sparing as possible. Another new technique would be the complete VATS approach, which is being published more and more, for example, from China. So you address all your chest wall injuries from within the chest rather than from outside, thereby preventing the dissection of the soft tissues. But non-operative treatment has been improved as well over the years. Nowadays, almost every country has a trans-trauma life support program, reducing mobility and mortality of all our trauma patients, including our chest wall injury patients. And there's an increase in awareness for chest wall injuries as well. So we're more known with the injuries, and we're more focused on aggressively treating them. Nowadays, we work in multidisciplinary teams with, for example, emergency physicians, different surgeons, but an anesthesiologist and the pain team are very important as well, as are dedicated nurses and physiotherapists. The energetic options are being improved. So instead of epidural, we use more and more plain blocks. Multimodal pain management is gaining popularity, and the intensive care has been improved as well in general. But for example, the improvement in ventilation is crucial. And like DJ already said, there will be more innovations coming the next couple of years. For example, cryo nerve block, which is extremely popular in pectus surgery nowadays, shows excellent results in terms of pain relief, morphine use, and mobilization. So in my opinion, that could be a next step for our rib fracture patients as well. So summarizing our own practice, what are my personal opinions? Normally, for flail chest injuries, we adhere to the CWIS guidelines. So if the patient comes in with a clinical flail chest, we offer him VATS-assisted rib fixation. The same accounts for the radiological flail segments with instability or those on ventilator. But patients with incomplete fractures, with fissures, patients with fractures in hard to reach areas, or in which you only have marginal gains, for example, you can only address 1 of 10 fractures, we start with non-operative treatment. And in that selection process, patient characteristics are essential. So we consider age, comorbidities, cognition, frailty, performance status, and we monitor the response to non-operative treatment very aggressively as well. by taking pain scores, scarf scores, and battle scores. For the multiple single rib fractures, we preferably offer non-operative treatment by aggressive analgesic regimen, like I already discussed the epidural or the erector spinae plane blocks. And we involve the physiotherapists very early, put them on TriFlow, and allow for early mobilization. Sometimes we do operate on those patients. We adhere to the CWIS guidelines as well, and we perform VATS-assisted surgical rib fixation in selected cases. For example, patients with severe displacement or chest wall instability, chest wall deformation, which sometimes developed over a couple of days or weeks. And if non-operative treatment fails, for example, inadequate pain relief, failure to mobilize, or an inadequate cuff reflex. And what is important that we adhere to shared decision making. So we apply a patient-tailored approach. So where are we today in this curve, this hype curve? I think we passed the peak of inflated expectations. We went through the disillusionment, and nowadays we're, well, I think halfway reaching the plateau of productivity. So I think we're managing to set our indications on an excellent level, and will be improving even further the next couple of years. So that brings me to my take-home messages. Rib fractures are very common injuries. The severity of chest wall trauma is often underestimated, and aggressive analgesia is very important. Most rib fracture patients benefit from non-operative treatment, but there's an increase in popularity of surgical rib fixation, and if you decide so, patient selection is essential. You should consider surgical rib fixation in all patients with a flail chest injury, and should only consider surgical rib fixation in selected cases of non-flail chest multiple rib fractures. If you have an indication for surgical rib fixation, please do it as soon as possible, but within 72 hours. The use of VATS is essential, and maybe the most important take-home message, the level of evidence of treatment needs improvement. Thank you very much.
Yeah, thanks a lot, Erik, for the presentation of your viewpoint, which in some aspects is not so controversial at all in the end. So we're already somewhat advanced in time. So for the participants, please, if you want to raise any issues of discussion, please go via the chat function or the Q&A. So maybe Didier, can you provide a very brief 2-minute rebuttal to Erik's talk?
I want to thank Erik for the nice words during the introduction. Thank you very much. It's kind of you. I think we agree. And I have insist also on this point that the literature is missing, lacking of evidence. And it's difficult because the problem is that if you want to perform a prospective randomized trial, it's difficult because the population of patient is very heterogeneous according to the comorbidities of the patient, according to the number of rib fracture, according to the localization. It's difficult to compare. I agree absolutely with you. And you are maybe also, I don't know, maybe it's right to say that we perform too many rib fixation. I'm not sure. For me, the point is, you have also insisted on this point that the rib fracture should be considered seriously. They are associated with a high rate of potential complication. The question is, in several subgroup of patients, should we take the risk that the patient develop complication according to the type of patient, young patient or old patient? It can be lethal for the old patient, for the young patient, they have a loss of work, of capacities. And for me, you have also shown it very nicely with the evolution of different systems. For example, the clip system, with the evolution of the minimal incision. I think the complication rate can be maintained very low. And in this situation, sometimes for selected subgroup of patient, I prefer to fix the rib. Also, if there is not really much evidence in the literature. It's my own expertise, and I can tell you in the morning the patient cannot move in the bed. You fix 2-3 ribs, and in the evening he can cuff and sit in the bed. It's a big difference. And you know this, you have also this experience, but it has to be selected. According the cost you have mentioned, the cost, it's always difficult. Cost analysis, of course, the material is expensive. Each clip or plate with screw is about 800, 850 euro. On the other side, when you see the patient taking during months, during years, medication and loss of work, it's also financially not very good. I think we agree. We are together. We should continue to fix the ribs in selected patient, but we have to remain critical. We are performing, for example, in our center. I have told you before to begin. A review of 600 patients, and we will analyze the complication, because it's important to remain critical and to make an internal control of quality. But I think there are really good indication for rib fixation. Also, if you have no proof in the literature, I think for several patients it's better. It's my own experience, but maybe I have a bias, yes.
Okay, thanks a lot. So, Erik, your rebuttal, and there was one question. Maybe you can integrate a comment on that. If you're in a low resource center and only surgical wires and none of the reconstruction materials you've shown is available, do you recommend also using such materials, or what would be a recommendation in this situation?
Yeah, I think that's an excellent question, because not every hospital has the facilities of a trauma surgeon, thoracic surgeon performing VATS, having a lot of implants, which cost a lot of money. So I think you have to have a basic knowledge and a basic experience to perform surgeries like this. And if you don't have the resources, it's always good to discuss the cases with the experienced center, referral center, and send the patient in. Because I agree with DJ, especially those flail chest patients, they really benefit from surgical treatment. So in order not to withhold proper treatment, it's always good to ask help from colleagues with more experience or centers with more resources.
May I ask you, both of you, as expert and thoracic surgeon, the example, I've begun with an example. It was in Switzerland, huh? High quality medicine. You have seen this man, 60 years old man. What do you think about it? So in this, was it a mistake for you not to operate on him when they have made the reposition of the stomach? I should have fixed the rib in this situation.
Yeah, it's always difficult in hindsight, because we were not there. We don't have all the information. But if that case would come in my center, I would aggressively fix the ribs as well.
Okay.
That's what we would certainly have done as well. So unfortunately, we've already gone over time. So we have to stop it here for today, even though there would certainly be a lot more points to discuss. I'd like to thank the both of you for your excellent presentations, and also the audience for joining in today. Finally, I'd like to point out our next ESDS webinar, which will take place on May 12th, and it will be a webinar focused on technical aspects of sleeve resections in its various forms, and I invite you all to join us there again. Thanks for today, and enjoy the rest of your evening.
Thank you very much
Thank
for
you
the
very much.
invitation again. Thank you. It was great. Thank you, Erik. Thank you, Clemens. Thank you. Have a nice evening.